Hello and welcome. My name is Aderonmu, and I'm going to be doing a presentation on the role of emotion and motivation in assessment and treatment of panic disorder. This presentation explores how emotion and motivation drive panic disorder symptoms and treatment. Emphasis is placed on physiological processes, evidence-based interventions, and adaptations for correctional, forensic, and community mental health settings. It explores panic disorder through the framework of emotion and motivation, emphasizing how emotional fear responses and avoidance-driven motivation shape the onset, maintenance, and treatment of the disorder. This presentation will be talking about um, correctional populations as well as the general community populations. Correctional populations because I currently work in a correctional setting and I do a lot of therapy with patient inmates, and I will also be touching on the general community-based populations as mental health populations as well. Overview of panic disorder. Panic disorder involves intense emotional fear responses that become self-reinforcing. Motivation to avoid panic sensations often worsens symptoms and interferes with daily functioning. When we talk about panic disorder, what is panic disorder? Panic disorder is defined by recurrent, unexpected panic attacks followed by persistent concern about additional attacks or maladaptive behavioral changes, such as avoidance. Emotion plays a central role as panic attacks are driven by intense fear and anxiety, while motivation influences behaviors aimed at preventing perceived threats. Over time, the motivation to avoid panic sensations reinforces the disorder and limits functioning. Physiological processes. Panic attacks originate from exaggerated threat detection in the brain, particularly the amygdala, combined with stress hormone activation that increases physical symptoms. Panic disorder involves hyperactivation of neural systems responsible for threat detection, particularly the amygdala, which rapidly interprets bodily sensations such as danger. Dysregulation of the hypothalamic pituitary adrenal HPA axis leads to excessive stress hormone release, amplifying the physical symptoms such as tachycardia and shortness of breath. These physiological responses increase emotional distress and trigger panic attacks. Autonomic nervous system. The sympathetic nervous system drives fight or flight responses, while impaired parasympathetic regulation prevents effective calming and panic episodes. The autonomic nervous system plays a critical role in panic disorder through an imbalance between sympathetic and parasympathetic functioning. Excessive sympathetic nervous system activation initiates the fight or flight response, while insufficient parasympathetic activity limits the body's ability to calm itself. This imbalance prolongs panic symptoms and increases fear of future attacks. Neurotransmitters and hormones. Imbalances in neurotransmitters contribute to heightened anxiety and poor emotional regulation, making individuals more vulnerable to panic. Several neurotransmitters and hormones contribute to panic disorder, including serotonin, norepinephrine, and GABA. Reduced serotonergic functioning impairs emotional regulation, while elevated norepinephrine increases physiological arousal. Decreased GABA activity reduces inhibitory control over anxiety, and elevated cortisol sustains chronic stress responses, collectively increasing panic vulnerability in individuals. Fight, flight, and freeze responses. Most individuals with panic disorder exhibit flight or freeze responses, leading to avoidance of places, people, and/or persons, or sensations that trigger panic. The fight, flight, and freeze response represents the body's automatic survival mechanism. In panic disorder, individuals most often exhibit flight responses, such as avoidance of places or situations, or freeze responses, including dissociation or immobilization. These responses are emotionally driven and motivated by fear, reinforcing avoidance behaviors that maintain the disorder. Causes of panic disorder. Panic disorder results from biological vulnerability combined with learned fear responses and catastrophic interpretations of bodily sensations. What are the causes of panic disorder? Panic disorder develops from a combination of biological predisposition, environmental stressors, and cognitive factors. Genetic vulnerability increases sensitivity to stress, while traumatic experiences condition fear responses. Cognitive distortions, particularly catastrophic misinterpretations of bodily sensations, intensify emotional reactions and motivate, which leads to motivation of avoidance. It leads to people being motivated to avoid situations, which contributes to symptoms persistence. So, what that basically means is that cognitive distortions, particularly catastrophic in misinterpretations of bodily sensations, intensifies emotional reactions and it motivates avoidance, which contributes to symptoms persistence in individuals. Comorbidities. Comorbid conditions increase severity and complicate treatment, especially in a correctional and/or forensic setting. Panic disorder frequently co-occurs with other mental health conditions, such as major depressive disorder, depression, PTSD, and substance use disorders. These comorbidities complicate emotional regulation and motivation, increasing symptom severity and impairing treatment engagement. In the correctional setting that I work at, I find that a lot of these comorbidities often intersect with trauma histories and institutional stress. Evidence-based treatment. There's a lot of evidence-based treatments out there, but cognitive, behavioral, and exposure-based treatments help clients reinterpret fear and reduce avoidance behaviors. Evidence-based treatments for panic disorders focus on altering emotional responses and maladaptive motivational patterns. CBT, cognitive behavioral therapy, helps clients identify and restructure catastrophic thoughts. I use a lot of CBT when working with a lot of my inmate patients because um, it helps replace the catastrophic thoughts with more positive thoughts. while exposure-based interventions reduce fear through repeated, controlled confrontation with panic sensations. Medications. Medications can be used in the treatment of panic disorder. Medications reduce physiological arousal and can support therapy, particularly when symptoms are severe. Medications can be used with therapy for individuals that are suffering from panic attacks or panic disorder. Pharmacological treatments such as SSRIs and SNRIs are commonly used to manage panic disorder by regulating neurotransmitter activity and reducing physiological arousal. While benzodiazepines may provide short-term relief, they are generally avoided in long-term treatment due to its dependency risks. So people we we ben, benzodiazepines are generally avoided because a lot of patients tend to depend on it. So it becomes because of its dependency risk. So we avoid this, especially when working with forensics and in correctional settings. It's generally avoided. Therapeutic techniques. Therapy focuses on helping clients tolerate distress and reduce fear-driven motivation to avoid sensations. Therapeutic techniques include psychoeducation to normalize panic symptoms. It also includes interoceptive exposure to reduce fear of bodily sensations and emotion regulation strategies is used to manage distress. These interventions directly target fear-based motivation and help clients develop confidence in their ability to tolerate anxiety and avoid without avoidance. Support needs. Support systems are very critical, very, very important for helping clients remain engaged in treatment and manage panic episodes safely. Effective treatment requires strong external and therapeutic support systems. A consistent therapeutic alliance enhances motivation and trust, while crisis planning helps clients manage acute panic disorder episodes safely. Psychoeducation for families or support networks helps reduce stigma and promotes understanding of panic disorders. So, providing psychoeducation to families of individuals that suffer from panic attacks or panic disorders really helps in the treatment of panic disorder because while the client is not in therapy, the family is able to understand and provide the clients or the individuals with the support they need outside of therapy. Cultural and population considerations. In correctional and forensic settings, panic may be misinterpreted as non-compliance. That's why trauma-informed and culturally responsive care is essential. Cultural beliefs may influence how panic symptoms are interpreted and expressed, with some populations emphasizing somatic complaints. In correctional settings, panic symptoms may sometimes be misinterpreted as aggression or non-compliance. That's why trauma-informed and culturally responsive interventions are essential to ensure accurate assessment and effective treatment. Clinical implications. Effective treatment addresses both emotional fear responses and motivational avoidance patterns to improve outcomes. We have come to the end of my presentation. Thank you so much for listening and God bless.